are addressing the whole health system. So just to have an overview about influenza more than just a respiratory disease, I would like to have Dr. Sonia Iqtidar over here. Dr. Iqtidar, an Iron Lady, distinguished physician, Cancunian, FCPS, FRCP London, Associate Professor of Medicine at King Edward Medical University. She is the founder Secretary General Pakistan Society of Internal Medicine and remained as Chairperson Dengue Expert Advisory Group from 2019 to 2021. She is representative International Dengue Organizing Group, Speaker for Asia Dengue Summit, and she has delivered numerous lectures and talks at national and international forums. She is primary author of Guidelines of Dengue in Pakistan. She has so many features in her crown like Governor's Award for Contribution to Health 2021 and Award of Excellence by President of Pakistan. She is Master's Trainer of WHO on dengue, an active member of Corona Expert Advisory Group. Having a clinical experience of more than 17 years and numerous publications to her credit, she is a part of many health advisory boards and forums. Over to you, Dr. Sonia. Let's welcome Dr. Iqtidar on the stage.
Thank you very much, Hina, for your very kind introduction. I think it's a little late in the afternoon, so everybody is tired. So I'm going to freshen you up by showing you some videos and reminding you of not so many years ago. So, 2019. This was 2019, ladies and gentlemen, and suddenly the time changed. And during 2020, this is what happened. So I'm sure everybody remembers this because this was the cover story of major publication. But you all must be wondering that why am I talking about COVID-19? I think the topic that was assigned to me was something else. But COVID-19 reminds us of pandemics. This was the pandemic of 21st century. But we had a pandemic in 20th century also. Many of us were not born. But we should all learn from our history. And if we don't learn, these pandemics are going to come one after another. We were lucky to be born in an era where we had antibiotics and vaccines which could end the pandemic. But there was a pandemic in the history which was a warning for all of us. The viral rage of Spanish flu in 1918 and 1919, which killed more than 50 million people, and for an estimate it is said about 100 million people, which was more than the people who were killed in the World War I, which was going on at the same time. This reminds us, ladies and gentlemen, that anything which kills over 10 million people in the next few decades, it's likely to be a highly infectious virus rather than a war. World War I, II, or III, that doesn't matter. What matters is our health, and that is at risk because of the microbes. So I am going to talk to you today about one of those pandemics that were part of history, but that doesn't mean that they've gone. They can hit us again. And they've been hitting in different parts of the world at different times. I'm talking about influenza. And when we talk about influenza, everybody thinks it's a respiratory illness. But what I'm going to tell you today that it is a respiratory illness, but it is more than just a respiratory illness. It causes significant morbidity, mortality, and social disruption. It has a big economic burden on the health sector. It is a health security threat. And since 2009, influenza A and influenza B, these viruses have been circulating in the human race. And the global attacks rates are estimated to be 5 to 10% in adults and 20 to 30% in the pediatric population. With about 3 to 5 million cases of severe illness and 500,000 deaths per year, we still have influenza within our community. 10 to 20% attack rates, and in some population up to 50%, which is the pediatric population. Pandemics occur infrequently, but we've had a pandemic in the past where about 1/3 of the world's population was affected. And now it's time to learn from our history. So influenza is a public health challenge, and the associated mortality tells us and reminds us that this is time to do something about it. A public health burden not only in some parts of the world, but in the whole of the globe. So if we look at the number of specimens positive for influenza by subtype globally, we come to know that there are different subtypes of influenza, but influenza A and influenza B are the major ones. And similar is the case in our part of the world, which is the Southeast Asia, where you see mostly influenza A and influenza B viruses. I'm quoting some of the studies from Pakistan for relevance, in which we have seen that severe acute respiratory illness or influenza-like illness has been reported countrywide. And this was a study which was done in 5 centers and sites, and influenza virus was detected in 24% of the samples. Out of these 24%, 72% were type A and 28% were type D. Similarly, in multiple studies from different parts of the country, like this is from PSIM, infants less than 2 years of age with different viral pathogens, influenza and parainfluenza were a major contributor. Similarly, in a study right here in Islamabad showed us that 75% of cases of respiratory illnesses due to viral pathogens, they had a major contribution of influenza A and influenza B. And this is similarly another study which was again done in this very city, Islamabad, which shows that there is a considerable number of cases being reported. But somehow in our routine practice, we do not test for influenza because the testing facility is not readily available, and it is available in the private sector and it is quite expensive. And ladies and gentlemen, let me tell you, influenza is just not a respiratory problem. It can cause shortness of breath and flu-like illness, but it can cause much more complicated diseases than it looks like. Like it can cause neurological diseases in the form of confusion, delirium, even GD syndrome and encephalopathy. In the respiratory system, it can exacerbate the already ongoing asthma or COPD, but it can also lead to severe viral pneumonias and death. In the kidneys, it causes rhabdomyolysis and acute kidney injury. In the heart, which is the major contributor of mortality, it leads to myocardial infarction and stroke, myocarditis and venous thromboembolism. It can lead to impairment in our glycemic control, and there is increased metabolic problems associated with this, leading to diabetic ketoacidosis because of impaired blood glucose control. It can also lead to pressure ulcers and weight loss and deconditioning. So it causes an 8% increased risk of stroke, 8% increased risk of severe pneumonia, 10% increased risk of heart attack, 74% increased abnormal glycemic events, and 23% experience loss of independence. So ladies and gentlemen, is it a respiratory illness? This is my question to you. It's not just a respiratory illness, a mild flu which will go away. It is a condition which leads to much more devastating effects in our body. And that is why it is very important to prevent this problem. The early ecological studies started to investigate cause-specific mortality during the influenza epidemics. And influenza accounts for about 15 to 30% of excess expected cardiovascular mortality seen during the influenza epidemic, which was ongoing between 1918 and 1919, extending up to 1920. And compared to the other times or off seasons, it is still observed that cardiovascular mortality increases during an ongoing influenza epidemic. So respiratory infections actually trigger myocardial infarction and stroke in a time-dependent relationship. So they not only increase the risk of MI post-ARI, but also the risk of stroke, contributing to cardiovascular mortality. And that is why Benjamin Franklin said that an ounce of prevention is worth a pound of cure. So we have to decide whether we want to invest in prevention or consume our resources in a not very fruitful way by curing this severe disease or illness. So that is why globally there is an influenza strategy for 2019 and 2030 going on, which aims to prevent, control and prepare us for influenza. The vision is to attainment of the highest possible influenza prevention, control and preparedness to safeguard the health of population. Then the mission that all the WHO countries and partners, they all collaborate to optimize and align the global as well as the national capacities for prevention, rapid detection and response to reduce the burden and impact of seasonal, zoonotic and pandemic influenza, with the goal to prevent and reduce the burden of seasonal influenza, control and minimize the risk of zoonotic influenza, and prepare, that is to mitigate the impact of pandemic, which God forbid can hit us anytime. And for this reason, the overview of the Global Influenza Strategy 2019 and 2030 emphasizes on promoting the research and innovation to address the unmet public health needs for improved and novel diagnostics, vaccines and treatments against this virus. Operational research for influenza prevention, control and program delivery, and to understand the virus characteristics and hosts that derive the impact of influenza. We need to strengthen the global influenza surveillance, monitoring and data utilization by having an enhanced, integrated and expanded virological and disease surveillance. We should build a strong evidence base for understanding the impact and burden of influenza, and this has to be generated by doing a local research and data collection. And develop an effective influenza communication strategies across multiple sectors and stakeholders to provide advocacy for prevention, and from prevention I mean vaccination of our individuals. So in order to do that, we have to expand the seasonal influenza prevention and control policies and programs, especially to protect the vulnerable population, and integrate the non-pharmacological interventions into prevention and control programs. We are all now focusing on NPIs and prevention and preventive health in communicable as well as non-communicable diseases. So we need to design and implement evidence-based immunization policies and programs to reduce transmission of this disease, and design and implement evidence-based treatment policies and programs to reduce the morbidity and mortality, which goes very well with our theme of the conference of evidence-based medicine, which should be patient-centric as well. So strengthening the pandemic preparedness in response for influenza will make the world a safer place, and for this reason, we need to strengthen national, regional and global planning to enable timely and effective pandemic readiness. And I am very glad that we are joined here together today by Professor Ton Ping. She is a strong advocate of influenza in Malaysia and globally as well, and respiratory physician Professor John Paul, who's President International Society of Internal Medicine, who will propagate this message on all scientific forums that we all must need to contribute to overcome these problems. World Health Organization has categorized some high-risk groups in our population who should be specially protected from influenza. And these include pregnant females at any stage of pregnancy, children between 6 months to 5 years of age, especially the elderly individuals aged more than 65 years, individuals with comorbid conditions like diabetes, hypertension, ischemic heart disease, stroke, or any other immunocompromised state, and our healthcare workers, all of us. We need to be protected if we want to serve our country better. And the impact of influenza, especially on maternal, adult and elderly population in Pakistan, needs to be emphasized, because there is increased risk during pregnancy. Increased risk of pneumonia leads to 2 lives, both of the mother and the fetus. It has impact on our hospitalization and economic, and it compromises immune system. If hospitalized patients get them, it gets very difficult to treat them. Elderly population also has a lot of comorbidities. They have high mortality rates, their healthcare utilization is more, and the quality of life can be compromised. So more and more emphasis should be done on this set of population. So talking about influenza vaccination, there are different types of vaccination available. Inactivated influenza vaccine, recombinant influenza vaccine, live attenuated vaccine, adjuvant influenza vaccine, high-dose influenza vaccine, but in our part of the world, we have quadrivalent influenza vaccine. Just to add to the information of everyone, we all know that these vaccines are produced every year, depending upon the circulating strain at that region, and they are produced every year. So for the time being, we have a quadrivalent influenza vaccine. The CDC, its guidelines and recommendations say that everyone 6 months and older should be getting a flu shot. And this is obviously CDC recommends for USA. But there are humans in every part of the world, and everyone, is at risk. But there are some vulnerable groups, as I told you, very small children, pregnant females, elderly, immunocompromised, and healthcare workers. At least they should be prioritized by the government policymakers and the healthcare professionals and societies to advocate for prevention and vaccination campaign for all of them. So for most people, we need 1 dose of influenza vaccine, and it is usually given in the September and October. But in some smaller children, we need to give 2 doses of vaccine. So the first vaccine and the second vaccine is given 4 weeks apart. Ideally, everyone should be vaccinated, but especially children 6 months to 5 years of age who are more vulnerable, pregnant females, healthcare professionals, people with chronic medical conditions, and elderly more than 65 years of age. In US and UK, it's part of the adult immunization program in the elderly population, but unfortunately, in a country like Pakistan, where we have a poor infrastructure of health, we are struggling to get a flu shot even by paying a price in the market. So elderly population, we all want to see our elderly population dancing and singing and being happy. But unfortunately, this is the vulnerable group. 65 years and older are at high risk of developing serious complications from influenza compared to the young and healthy. So therefore, they need more emphasis on detecting influenza, prevention, and early treatment if they get it. And the fever may not be a very prominent feature in elderly population, and the presenting complaints may instead be exacerbation of any underlying health condition like congestive cardiac failure or exacerbation of asthma or COPD. So we need to be vigilant in them. There are lots of studies which have been published that the disease burden of influenza is beyond the respiratory illness, and individuals with chronic medical conditions account for as many as 80% of the hospitalizations for influenza in adults and approximately 50% of them in the pediatric population. So there's a functional decline in the activities and daily living, and older adults usually they are frail, and if influenza infection catches them, they have the highest deterioration in the ability to perform even the basic activities of the daily living. So there is a domino effect of influenza, and the influenza virus triggers various effects that can exacerbate the underlying chronic medical conditions, leading to an increased risk of hospitalization and death. So there are so many things that the virus can do. It can lead to not only respiratory complication and exacerbation of asthma, COPD, and pneumonia, but it can also lead to increased risk of myocardial infarction and stroke. It can lead to diabetic complications. It can lead to neurological complications and decline in the cognitive function of the individual. And especially in older population, in elderly people, a retrospective review of lab-confirmed influenza showed that 77.2% of death occurred in more than 65 years of age, and 3 times the odds of dying during admission compared to young adults if you are older than 65 years of age. So the percentage of influenza-related illnesses, medical visits, hospitalization and deaths of age groups between 2019 and 2020 were studied by some of the scientists, and then this study was done in US, and the hospitalization and deaths to influenza are the highest among older adults of more than 65 years of age. There are multiple studies which show that our older population is at greater risk of hospitalization and death. This is a study courtesy of my friend Professor Pin from Malaysia, in which there was a retrospective study of 3,935 patients with upper respiratory tract infection, and 11.9% of them tested positive for influenza. And fever occurred less commonly among cases who were more than 65 years of age, and the risk of hospitalization or death in individuals in more than 65 years of age was significantly greater compared to the individuals who were young and less than 25 years of age, as you can see in this picture. So age is an established factor, and you should be very careful in seeing the elderly population if they come across symptoms of flu and upper respiratory tract infection to check for influenza. So apart from the elderly population, maternal and adult population, especially adults with underlying health conditions and healthcare professionals, these are the two groups that need our special attention. In the maternal population, we know that there are physiological changes going on, and there is limited vaccines which are approved during pregnancy. And they can have adverse outcomes if they are not protected, because not one but two lives are at risk. So they should be advocating the use of vaccine in such population. So the importance of vaccination as a preventive measure, I just wanted to emphasize over here that there is a myth that vaccination is for pediatric population. But we all know that vaccines help in preventing the disease, protecting the vulnerable population, reduce the spread of the disease, they decrease the healthcare costs, they eradicate and control the disease pandemics, they prevent the complications and mortality, they make us learn and become prepared for pandemics, they improve the quality of life, and they are overall important for global health security, because after all, we all live in a global village. So influenza vaccine in older adults has been seen to be very, very effective, and the meta-analysis has shown that it has shown 41% effective efficacy in all ages and 37% in more than 65 years of age. And reduction in admissions for influenza or pneumonia is also considerably high if we use these vaccines. So it is overall an efficacious vaccine. It should be given to the pregnant females to save both the mother and to pass on the advantages to the newborn fetus. And for adults with underlying health condition, we can not only reduce the disease incidence but decrease the complications and reduce the disease transmission by the factor of herd immunity and reduce the hospitalization and healthcare costs. So just my take-home message that adults don't get vaccinated. This is something for children, for pediatrics. So vaccines are only for children, we often hear. I received vaccination full course during my childhood, so I don't need them now. Vaccines are not effective. There are so many anti-vaxxers. I'm seeing some faces from UK and US here where there's a strong anti-vaxxers campaign, and even in Pakistan. And I can get the disease anyway. Even if I get the shot, I get the disease. What's the point in taking a flu shot? Vaccines are not safe. I'm not very sure about the side effects, the serious problems it can cause. I'm not confident that I should be taking one. I'm healthy. My health is, I never get a fever. I don't need a vaccine. My immunity is first class. Natural immunity is better than the vaccine-induced immunity. And then the problem of the low and the middle income countries. I can't afford vaccines, or vaccination is not covered by my state or my insurance. So the lack of awareness, limited health education, misinformation, accessibility, both geographical barriers and high healthcare costs, vaccine hesitancy because of the safety concerns, religious and cultural barriers, limited healthcare infrastructure, and the availability of vaccines. These all are the common barriers to vaccination in Pakistan. But we need more public awareness and education improved access, healthcare providers training, reminders, systems and incentives to increase the vaccination in adults, and partnerships and monitoring at the global level for our continued efforts to improve the health. So I will end here by saying, vaccines don't save life. You might be thinking that there is an error and I wanted to write vaccines save lives. But ladies and gentlemen, vaccines don't save lives. Vaccination does. Get yourself vaccinated. Thank you very much for your attention.
The varying prevalence rate influenced by factors such as age, socioeconomic status and geographical location, the intricate mechanism with different treatment strategies, all about the treatment of H. pylori infection. The emerging trends in antibiotic resistance and personalized treatment approaches needs to be addressed, emphasizing the importance of tailored management plans for individual patients. To have a detailed talk about H. pylori management, I would like to have Professor Azizur Rahman over here. He is physician par excellence, best graduate of his time at Al Medical College. He worked in various capacities at Al Medical College, Services Institute of Medical Sciences, King Edward Medical College, and Rashid Latif Medical College as well. He is Senior Vice President, Pakistan Society of Internal Medicine. He is Editor, Journal of Pakistan Society of Internal Medicine, and former Editor-in-Chief of SPLW, the Official Journal of Services Institute of Medical Sciences. He has more than 60 publications to his credit. Teaching is his passion, and he has delivered numerous lectures on various topics on different platforms. He has his own YouTube channel by the name of Understand Medicine. We warmly welcome you, sir, over the stage. H. pylori management by Professor Azizur.
Generous introduction and honorable chairs, foreign and local faculty, delegates and my students. I was asked to talk on the management of H. pylori, and you know, management is not just a treatment. First you have to understand the disease and you have to diagnose the disease and then you can treat. So I have added these components also. So presenting on behalf of Abbott Laboratories, but there is no financial implication, and I don't think I'm going to receive honorarium also. The contents are entirely my own. The Helicobacter pylori, this is the picture, is one of the most robust organisms. It was discovered in 1983 by Warren and Marshall in Australia. They won Nobel Prize for this. Acquired through oral or fecal-oral. Oral like kissing or even non-sexual kissing or food contamination. Sharing food could transfer the infection. And fecal-oral like poor personal hygiene, somebody handling food and that can transfer the infection to the other one. This organism lives mostly in the mucus layer of the stomach. It could go deeper. It could cause bacteremia also, and in some cases it may cause at least some antigenemia. It has got double cell membrane, and that makes it very, very tough organism to eradicate. And it is also equipped with some specific enzymatic system which is responsible for the pathogenesis and the disease already. And it has been identified as group 1 carcinogen. That means we are very sure that this can cause cancer in the stomach. So the first question is H. pylori a friend or foe? It may be a foe because it causes gastritis, it can cause gastric and duodenal ulcer and further complications like bleeding and rupture, and it may cause malignancy. But it may also be called a friend because it had lived with us for millions of years, just like a commensals. There are so many people who are infected, at least as far as antibodies are concerned. They are infected or they were infected, but they don't have any symptoms. And there is evidence that H. pylori may actually protect you against certain allergies, asthma, celiac disease, and some infection. So what turns this friend into foe, we don't really understand. At least I don't. Something happens at this H. pylori, which was present in the stomach, sleeping, hibernating, suddenly becomes active and decides to cause a disease. So in pathogenesis, first of all, I think this germ has got the ability to survive in a highly acidic environment. In summer, the pH could be as low as 2. And most organisms, they cannot survive in this acidic environment. In fact, our gastric acid is like one of our immune mechanisms. But this organism has got a special mechanism. It has got the ability to split urea into ammonia, ammonia being an alkali. And this bacterium moves with a cloud of ammonia, alkalinity, and it can survive in the mucus layer. And it also stimulates gastrin-producing cells and cause increased HCl production. It can also inhibit somatostatin producing cells that they are protective, so both of them may be actually responsible for causation of peptic ulcer, both duodenal as well as gastric. And it also enhances cellular growth and may cause metaplasia, and that can be responsible for cancer, both the mucosal cancer and also the lymphoid tissue in the stomach that can also turn into cancer. It actually produces many cytokines, and these cytokines are absorbed, and they may cause many other symptoms, like may cause malabsorption syndrome, and they may also cause many systemic symptoms, many unexplained chronic symptoms like chronic fatigue syndrome, myalgia. They can also be attributed to H. pylori infection. Importance may cause chronic atrophic gastritis, and due to atrophic gastritis, it may impair absorption of many nutrients like vitamin B12, vitamin D, and folic acid, and other iron, may cause gastric ulcer, duodenal ulcer, and may be responsible for non-healing or recurrent ulcer. It has been observed, if there is somebody who has H. pylori induced peptic ulcer, and if you give him a good dose of PPI, most probably the ulcer will heal. But the chances of recurrence are very high unless you eradicate this organism. Malignancies, adenocarcinoma, marcoma, and esophageal cancer, they of course are very, very good reason to treat this organism. Many extrahepatic manifestations like ITB, in some people with ITB, this organism may be a trigger point, iron deficiency anemia, ischemic heart disease. There could be what is called coronitis. The coronary arteries get inflamed and they can cause ischemic heart disease and many other conditions, and one of them is chronic fatigue syndrome. So people who we treat them as fibromyalgia or depression, some of them may be actually suffering from H. pylori infection. Now, these are the symptoms of GIT. And you can see nausea, vomiting, abdominal pain, heartburn, diarrhea, erythrosis, plus many systemic symptoms. Now, diagnosis, I think these are 5 tests which can be used. If you have 5 tests or 5 treatment options for one disease, that means none of them is 100% satisfactory. Now, I'm going to talk about them one by one. First of all, antibody test. It's an easy test. It is used for screening. So a positive test would mean that this person is suffering from or had suffered from H. pylori infection. It does not indicate a current infection. And it is not useful to check the efficacy of the medication also. So diagnostic value is only positive. If somebody was known to be negative only recently, and now the test has become positive, with symptom, I think then this test can be considered diagnostic. Stool for H. pylori antigen, it is little cumbersome because I realized that people do not feel very comfortable collecting their sample of stool and giving it to the laboratory. But it confirms current infection or at least colonization. A positive stool antigen would mean at least the presence of H. pylori in the stomach. It is very, very specific, 98%, and very sensitive, 94%. So quite useful test, very expensive, I think 500 to 5,000 rupees in Pakistan. It is used to confirm the diagnosis and also to confirm eradication. Widely available, most laboratories are doing, and now the home kit is also available. So the principle of urea blood test, I love to talk about this. It's a very interesting test and very convenient. I think in the West, this is probably the first screening test, the diagnostic test. So somebody, when you suspect H. pylori infection, you would give him this drink. It has got urea, that is carbon 13. Normal carbon is carbon 12. Carbon 13 so that we can change this. In a normal healthy person, this will just pass through the stomach in the stool. But if you have some organism in the stomach which is producing urease, that will split this urea into ammonia and carbon dioxide. And this carbon dioxide can be detected because it has got carbon 13. And the only organism, there will be an assumption that there is something which is producing urease in our stomach, because our normal stomach cells, they do not produce urease. So if there is the presence of urease would imply some organism which is producing urease, and there are many organisms which can produce urease, but the only one which can survive in that highly acidic environment is H. pylori. So we assume that there is a H. pylori. This would be exhaled into the air and can be detected. So this is how it is detected. I will not go into the details because of the time is a problem. So this is the technique. Patient uses the scale, collect the sample, 3 or 4 samples before taking the drink, and then after that, and then is sent to the laboratory. So the diagnostic value interpretation confirms current colonization and infection, very specific 98% and sensitive 94%, used to confirm eradication, and home test kit is also available. So endoscopy, I think, is a very definitive test, but many people, they hate to undergo endoscopy. It is most definitive test. It is definitely indicator where you suspect that there could be something else. And as a good clinician, in all clinical situations, you should always ask yourself what else it could be. So especially in elderly people, especially those who are not responding to treatment, you must suspect some other condition. So I think endoscopy should be done. So with endoscopy, you could have normal appearance, you could have appearance of chronic gastritis, atrophic gastritis, intestinal metaplasia, dysplasia, gastric adenocarcinoma, or margoma. So all these are possible on endoscopy. So once you get the sample, you of course take the biopsy. You first see the picture. This is the picture of gastritis. I see some gastroenterologists here. Please excuse my ignorance. The picture does not really represent gastritis. So, and one simple way of testing for urease is this rapid urease test done on the biopsy specimen. And the principle is that the tube on the left has got some reagent which is yellow in color. And if you change the pH to alkali, it would turn pink. So the biopsy specimen is put in here, and if it is H. pylori, that will make urease, and that will produce ammonia, and that will turn the reagent pink. So next time you see it is pink, you would assume that this is H. pylori also. Or the biopsy could be seen under microscopy. H. pylori can be identified with H and E staining or Jameson staining. Culture and sensory is usually very difficult because this organism is very, very demanding. It is not easy to know, although the scientists have developed the technique, but it's not routinely done. It's not easily culturable. And molecular test, the PCR, is very, very promising because it has got 100% sensitivity and 100% specificity. What else do you want? One test which will tell you surely if H. pylori infection is there or is not. Plus, it can also tell you the resistance to clarithromycin, which is the primary treatment. So I think it's a great test. PCR, I think, should be the standard test for diagnosis of H. pylori infection. So this is the picture histology, and these H. pylori, they can penetrate into the crypts. I think the question is, treatment, you have made the diagnosis, should we treat or should we treat it? I earlier said it could be 4 or 10. So pros and cons of treatments are discussed, and I think the physician will make his own judgment. It will remain an individual decision of the physician whether to treat or not to treat the given the individual. So pros in favor of treatment, recurrence rate very low. If you don't treat, eradicate H. pylori, peptic ulcer would come in about 90% of the case in one year. And if you eradicate it, the chances of recurrence of ulcer is less than 10%. Prevention of cancer, very, very good reward, and psychological relief. Somebody who is suffering from some infection knows that this infection is over, would get a lot of psychological relief. And then the risk of transmission to other blocks will minimize. So all these points favor the treatment. But let's see the other side of the picture. Many positive cases are asymptomatic, especially positive only on antibodies. They are asymptomatic. It is very difficult to convince somebody to get a difficult to tolerate treatment who is asymptomatic. No 100% effective treatment is available, and all treatment available are characterized as an unpleasant side effect, and recurrence from the same source is very high. If the source is contaminated community water, that person after a very difficult eradication is going to go back to the same community and going to drink the same water and going to get the same infection. So I don't see these points unless you can improve overall hygiene condition of that person, family. So you will decide whether or not to treat. Several regimens are available. None is 100% effective. None is clearly better than others. All have unpleasant side effects. And PPIs or PCAPs are always included because antibodies do not work in very acidic environment. Now compare it with chronic hepatitis C infection. For chronic hepatitis C, we just have one pill which works in almost all individuals, almost close to 100% response rate, and the tolerability comparable to placebo. Now compared to this, here nothing is ideal. So it's a very, very difficult, actually, challenging task to treat these patients. So there are 3 lines of treatment: first line treatment, second line treatment, third line treatment. The best is first line. The most effective is first line. Don't think that the second line or the third line is more effective. Just like in TB, the first line is the most effective treatment. Second and third are the only left choices if first line does not work. So the first line treatment consists of many regimens actually. Clarithromycin-based triple therapy and clarithromycin-based sequential or triple therapy. There are other ones, non-bismuth for triple therapy, bismuth-based therapy, levofloxacin therapy, concomitant bismuth-based therapies, but I'm going to talk about in some more detail for the first 2. So you give proton pump inhibitor anyone, like omeprazole or any other one, rabeprazole, usually double the recommended dose. If you use omeprazole, you will give 20 mg twice a day, and you give it for 2 weeks. Along with that, you give antibiotics, clarithromycin, 500 mg twice a day for 2 weeks. Literature says could be 10 to 15 days. I always give them for 15 days because I know, and the literature supports my idea, that the longer duration improves the chances of eradication. And amoxicillin 1 gram twice a day. So both of them could be taken in this dosage for 2 weeks along with double dose of omeprazole or the PCAPs. PCAPs are not only a good substitute of PPI but can be actually more effective. There is one study which shows that it is better than PPI. And after 2 weeks therapy, patient must continue the PPI for at least 2 weeks. And with this regimen, the efficacy is around 80%. If patient takes the medication, the way it is recommended, 80% max. And the other regimen is clarithromycin-based quadruple sequential. Now this is actually again first part is the same PPI or PCAS double dose for first 10 days. And first phase is to give amoxicillin 1 gram BD Since patient is taking just one antibiotic at this time, maybe patient can tolerate it better. And the theory behind this is that this organism has got double cell wall. By giving amoxicillin, we make the cell wall defective. That means the antibiotic in the second phase will penetrate the germ better and they will produce better results. So the first 5 days, amoxicillin 1 gram twice a day. It should be followed by 2 antibiotics, clarithromycin 500 milligram twice a day for 5 days and tinidazole 500 milligram twice a day for 5 days. So total is 10 days. These two drugs, they may cause side. Amoxicillin would cause GI upset, but otherwise it's okay. But clarithromycin and tinidazole is going to, I think, cause definitely bitter taste in the mouth because both of them are notorious for this. This again will be followed by treatment with just omeprazole for 2 more weeks. And the efficacy of this sequential quadruple therapy, clarithromycin based, is 90%. So this sounds little better than the first line. Both are considered the first line treatment. Now, along with these antibiotics, you also give some supportive treatment. There is some evidence that the multi-strain probiotics may be helpful because H. pylori can also cause dysbiosis. So, multi-grain probiotics may be helpful, and broad spectrum vitamins, minerals, and trace elements should also be given because you don't know which element is deficient because of the gastritis. Patient will be suffering from some of these micronutrient deficiency which may be responsible for some of the symptoms. Antidiarrheal, simethicone, and antacid. When I was preparing this presentation, I went through this some natural. So this L is missing. Some natural remedies. Mastic gum is something which comes from Mediterranean tree, and I don't really know what this thing is, but this as a therapy has got about 60% eradication rate. Then black cumin, kavanji, curcum, haldi, curcumin, haldi, ginger, licorice. They're not only great in taste and flavor and spice, but they also cure your H. pylori. Then some foods, some anti-inflammatory foods like broccoli, honey, red wine, cranberry, and green tea. They're all supposed to have some beneficial effect in H. pylori. Of course, I will always give them as a supplement to antibiotics because they are more scientifically validated treatments. Now, overall treatment plan and retesting, first of all, you establish the diagnosis. You discuss the treatment plan with the patient because we all agree that patient has to be in the center of decision making. Patient has to be an active partner. You discuss the cost, you discuss the expected side effect, you discuss the reward and all the things, and then you decide whether or not to start the treatment. And then execute treatment consisting of 2 antibiotic regimen I just mentioned. And then 2 weeks after the antibiotic course is completed, 2 weeks just PPI or PCABs. Another 2 weeks, patient should be off PPI and PCABs. And then you retest. And you don't retest with antibodies. You don't retest with the gastroscopy also because patient do not like that. So you test with a non-invasive test. I think this breath test, urea breath test or stool is called NDL, both are great. Be prepared to expect that this test may still be positive because all do not respond. So a patient has got symptomatic improvement and test is still positive. I think I would give him some more time and retest after 4 weeks. Patient should be off antacid and ranitidine also for 24 hours before you do this test. And patient should be fasting for at least 12 hours to get the test right. So whether screening and treating asymptomatic individuals, does that make any sense? I think there are trials that if the people who have some vague symptoms and you may screen them for possible H. pylori infection, and studies have shown that it will be a cost-effective approach. So to sum up, H. pylori infection is extremely common. The prevalence is according to one's age. Average 50%. If I'm 68 years old, I have 68% chances that I may be suffering or had suffered from H. pylori infection. So extremely common. Eradication should be considered in symptomatic patient and confirmed case, because treatment is hard and treatment is not effective in 100% of the cases. So it's only symptomatic people and confirmed cases. Gastric martyroma, however, is a definite indication for H. pylori eradication because it improves the outcome. Clarithromycin-based first-line therapy should be the first choice. Again, I say it does not work in 100% cases, but it is better than other. We have hybrid regimen, we have other regimens. I think it is still better than others. So that should be based. Either you use clarithromycin-based triple therapy or clarithromycin-based quadruple sequential therapy. This should be tried first of all. Screening of people with vague GE symptoms, systemic symptoms is warranted. And asymptomatic, this is my own approach, you may disagree. Asymptomatic people without definite evidence of H. pylori are best left alone. So I hope I was able to make a simple version of this complex topic, and because my colleagues know the simplicity is in my gene.